Good morning. My name is Rajneesh Mahajan. I'm a child and adolescent psychiatrist at Kennedy Krieger Institute in Baltimore, Maryland. I'm also an assistant professor in the Division of Child and Adolescent Psychiatry at Johns Hopkins University School of Medicine. It's my pleasure to be presenting today on problem behaviors that are commonly seen in neurodevelopmental disorders. My objectives in today's presentation will be to talk about current understanding of problem behavior in neurodevelopmental disorders. Second will be to talk about how to approach the assessment of problem behavior. And third will be an overview of treatment approaches to manage problem behavior. I don't have any financial or ethical conflicts of interest. So when we talk about neurodevelopmental disorders, these are disparate conditions, which means that they have varying causes, and they've been grouped together because they involve disruption of brain developmental processes. These conditions or these disorders, they have neurological or psychiatric or behavioral consequences. Because of various causes, there is significant heterogeneity in their clinical features, in their course, and the long-term prognosis. One thing to know is that genetic and metabolic disorders, which may not be listed in the current classification of neurodevelopmental disorders, may also have neurodevelopmental consequences. And this includes autism spectrum disorder. So 10 to 20% of individuals who have neurogenetic syndromes may have autistic features. And conversely, about 5 to 10% of individuals with autism spectrum disorder have a known genetic cause. So genetic causes are very important in neurodevelopmental disorders. So this slide shows the range of neurodevelopmental disorders. This was a new category introduced in the Diagnostic and Statistical Manual of Psychiatric Disorders in the 5th edition, which was released in 2013. Notably, ADHD was included in this category as a neurodevelopmental disorder, along with autism spectrum disorder, intellectual disability, tic disorders, etc. One thing to note would be that fetal alcohol syndrome, which had not been included in previous iterations of DSM, was included in this category of neurodevelopmental disorders under other neurodevelopmental disorders. The other concept to understand is, there is a term called irritability and how it relates to problem behavior. So when we talk about irritability, it refers to the vocal and motoric outbursts that may occur in an individual with neurodevelopmental disorder. These are usually expressive of anger, frustration, and distress. In common parlance, they are referred to as meltdowns, temper tantrums, and rages. So when we talk about problem behavior, these are directed acts of aggression that have a high potential to do result in harm to other people, self, or property. And frequently, problem behavior is associated with irritability. The thing to understand is that irritability itself is a non-specific symptom, which means that it can be seen across different diagnoses. But when these are studied or treated, irritability and problem behavior are frequently considered together, and it can be very confusing when you're looking at the literature. One approach that some people have taken is to designate all interfering or problematic behaviors as problem behavior. And these can be classified into three categories. One is the aggression, or what used to be called challenging behavior. The second is physiologically driven behavior. And third is heightened core features of the diagnosis, for example, an autism spectrum disorder. Challenging behavior is used or has been used commonly in over the years, but carries a pejorative sense to it, and therefore generally it is avoided. I personally don't use the term challenging behavior because the question is, who is it a challenge for? And does not describe the behavior. So challenging behaviors, or aggression includes aggression towards others, which is the classic aggressive behavior. The aggression directed to self, which is called self-injurious behavior, and aggression to the environment or property. And these are called disruptive and destructive behaviors. The second type of problem behavior is physiologically driven behavior. These include behaviors around sleeping and feeding disorders. Pica is an example of such a behavior. The third category is heightened core features. So children with autism, for example, will have at different times worsening of their features of autism, the core features of autism, and these can interfere with their functioning. And these may include restricted interests and preoccupations, behavioral rigidity, insistence on sameness, and sensory sensitivities. The thing to understand here is that these behaviors, they can have an impact on each other. So heightened core features of autism spectrum disorder can worsen aggressive behaviors, especially when, for example, somebody tries to stop the child from engaging in those behaviors, even if the behaviors are affecting the functioning of the child. Similarly, feeding difficulties can lead to aggressive behaviors. And these aggressive behaviors can in turn worsen the physiologically driven behaviors and worsen the intensity of the core features of autism spectrum disorder. So there is an interplay between these different problem behaviors. So for our practical purposes, when we say problem behaviors, I will be referring to the aggressive, self-injurious, and the disruptive and destructive behaviors as problem behaviors. This is a busy slide. I apologize for that. But biological, psychological, and environmental factors may play a role in either inducing or increasing the risk of development of problem behaviors. The severity of core features of autism have been found in studies to have increased the risk of developing problem behaviors. And this is exactly what I had mentioned. For example, behavioral rigidity, insistence on sameness, repetitive behaviors, focused interests, and sensory sensitivities may all worsen the aggressive, self-injurious, or disruptive behaviors. Having more severe intellectual disability also increases the risk of developing problem behaviors. And usually problem behaviors are seen early in development, and frequently if someone has communication difficulties. The problem behaviors can vary across settings. So you may see problem behaviors in a particular environment. For example, these behaviors may be worse at home as opposed to school, because the child may respond to the structure at school. Conversely, these behaviors may be worse at school when demands are being placed by the teachers. And there's always an antecedent or trigger that may trigger these behaviors. There might be some factors that might actually reduce the likelihood of problem behaviors. For example, giving social attention or actively ignoring some of these behaviors. Comorbid conditions may drive these behaviors. These behaviors may cause severe disruption in the functioning of the child, lead to caregiver stress and burnout, and they interfere with learning of the child and reduce the quality of life. These are examples of some of the challenging behaviors that are seen in neurodevelopmental disorders. For example, aggressive behaviors may include hitting, biting, scratching, headbutting, body slamming, chinning, and pinching. Self-injurious behaviors may include headbanging, hand-to-head hitting, knee-to-chin hitting, biting, scratching, digging, insertion of objects, etc. And disruptive and destructive behaviors may include what are typically called tantrums, oppositional behaviors, throwing objects, breaking objects, inappropriate sexual behaviors, elopement, and other property destructions. One thing to understand is that the aggressive and self-injurious behaviors may not have the intentionality that is usually associated in individuals who may be higher functioning cognitively. Planned aggression is not usually seen in those with moderate to severe intellectual disability. And usually the aggressive behaviors are impulsive in nature or part of a behavior pattern. Self-injurious behaviors, when we refer to in severe neurodevelopmental disorders, they may not be part of a suicide attempt that may be seen in individuals who may be higher functioning, where they may be called deliberate self-harm. There are several factors that may affect problem behaviors, including developmental delays, communication abilities, medical comorbidities, mental health comorbidities, a mismatch between demands and abilities, and social stressors. And when we assess and treat these behaviors, a developmental approach is necessary. So the common comorbidities that we see in neurodevelopmental disorders can be medical comorbidities, especially head trauma, seizures, hearing and visual impairments, feeding disorders, constipation, and other metabolic disorders. And the mental health or psychiatric comorbidities may include the whole range of diagnoses, but more commonly ADHD, anxiety disorders, mood disorders, disruptive mood dysregulation disorder, OCD, tic disorders, psychotic disorders, catatonia, or PTSD. And just to clarify, comorbidity refers to occurrence of two or more conditions in an individual. Co-occurring disorders is another term that is used for comorbid conditions. 70% of children with autism spectrum disorder have been found to have at least one comorbid psychiatric disorder. The two most common conditions are ADHD and anxiety disorder. So that leads to formulation of a treatment plan. A comprehensive treatment plan for a child with neurodevelopmental disorders may involve several professionals. This plan may spread across disciplines and frequently can be very complex. It takes time to implement the treatment plan and can lead to a huge caregiver burden. And therefore, there has to be communication between various providers who are involved in this treatment plan. The treatment plan is driven by the assessment of factors that may potentially be contributing to the problem behaviors. This is an example of a treatment algorithm that was developed through Autism Treatment Network, which takes into account the factors that may affect development of problem behaviors. So how do we treat problem behaviors? So first of all, there has to be an interdisciplinary team approach. Parents play an integral part of the treatment team. Sometimes school professionals may be involved. And generally there are core team members, for example, a psychiatrist, a behavioral psychologist, a social worker, speech and language pathologist, occupational therapist, and then other professionals who may be involved depending upon the needs of the child. A comprehensive psychiatric evaluation is necessary at the outset, and similar evaluations may be done by various professionals involved. Collateral information is important it is important to gather information across settings. How is the child at school? How is the child at home? How is the child in the community? The more information we have, the better the treatment plan. Thorough longitudinal history of development is important, as well as of emergence of the mental health symptoms. And generally, we try to establish a baseline and then look at when the problem behaviors began to be seen, or were there any other mental health changes? Are there any diagnosable mental health diagnoses? Are there any medical conditions that may be contributing? Some medical conditions may lead to development of psychiatric problems. Upon physical exam, is there a known behavioral phenotype that may be associated with the presentation? And then medications. A lot of medications can cause side effects. Are the behaviors due to a medication that is being prescribed? Are the symptoms severe enough that they are impacting the functioning of the child? Have there been previous trials of psychotropic medications? And what was the response to these medications? So as part of the assessment, the other piece is, are there any safety concerns? Are there any psychosocial stressors? And is there any caregiver stress or burnout? And generally speaking, safety concerns guide the level of care that the child may need. Is there a risk of significant harm to self, to others, or property? Is there an imminent risk of physical harm to self or others? Is it a crisis situation? Ultimately, this assessment requires clinical judgment. And the goal is to manage the patient in the least restrictive setting. And these levels can vary from outpatient treatment, which is the least restrictive, all the way to inpatient, which is the most restrictive setting, and is generally needed when there is a safety concern or there are chronic safety concerns. Unfortunately, for any patient to be hospitalized, one has to go through the emergency room, which leads to a big problem as there are limited inpatient hospital beds for patients with neurodevelopmental disorders, which leads to psychiatric boarding of patients in the emergency room for prolonged periods of time. Behavioral interventions are typically used first or in combination, depending upon the needs of the child. The most commonly used approach is applied behavioral analysis, in which a functional behavioral assessment is conducted to identify the antecedent stimulus and understand the function of the behavior. And generally the focus is on understanding whether there is escape, avoidance, or access to tangibles that may be driving the behaviors. And then replacing these dysfunctional behavioral patterns with more appropriate behaviors. The challenges include the generalization may be difficult for the child across settings. It takes time to replace these behaviors, and there's a shortage of providers and long wait lists, which limits the use. Another thing is that caregivers may not be able to consistently implement complex behavior plans due to constraints on their time, as well as understanding of the behavior plans. The medication management that is used is directed to target behaviors or symptoms. The goal is to reduce the intensity of or manage interfering behaviors or symptoms. These do not treat the core features of the neurodevelopmental disorders. And generally, medications are used when the conditions are impacting the learning or interfering with the functioning, if there are safety concerns, or if behavioral approaches or other non-pharmacological approaches are not successful. There might be some preliminary workup that may be needed, for example, an EKG with certain medications. And generally, when we treat, we start with targeting one co-occurring condition and then optimize the medication to an effective dose and then treat the other conditions. These medications, the psychotropic medications that are used to treat problem behaviors and co-occurring conditions, they modulate neurotransmitters, and the most common neurotransmitters include serotonin, dopamine, noradrenaline, acetylcholine, glutamate, and GABA, and endogenous opioids. The medications that are used, they target these neurotransmitters. These neurotransmitters, they facilitate or block communication in the developing pathways and can interact with each other in complex ways, as the figure shows. Psychotropic medications can enhance or reduce this communication between neurons. So this is a chart of an overview of treatment of mental health comorbidities with various medications. The discussion of all these medications is beyond the scope of this presentation, but I will focus on the medications that are used to treat irritability. The most validated treatment, or the treatment for which there is evidence, are the atypical antipsychotics. In particular, risperidone and Abilify are the two medications that are FDA approved for treatment of irritability in autism spectrum disorders. Other medications have also been studied. There are several studies using olanzapine, ziprasidone, paliperidone, quetiapine, etc., but the evidence is not convincing. Clozapine is used for refractory cases or when other medications are not effective. There are many side effects to atypical antipsychotic medications for which the child should be monitored by the treating provider. Mood stabilizers and anticonvulsant medications are used. For example, lithium, divalproex, lamotrigine. These medications are used if there is a lot of mood dysregulation, or there's a diagnosed bipolar disorder, etc. But again, these medications also required monitoring of blood work. Lithium, although it's very effective, can go into an unsafe category very easily, and the blood levels of lithium have to be monitored closely. Another type of medication that is commonly used to treat problem behaviors are the alpha agonists. There are two medications in this category, guanfacine and clonidine, and these are available as extended release preparations in the United States. These have been approved for treatment of ADHD symptoms and reduce hyperactivity and impulsivity, but they also help with behavioral and emotional regulation, and therefore the problem behaviors. They may have some indirect effects on treatment of anxiety symptoms. Other medications are also used, but there is limited evidence for these medications. At the end, brief word about cannabis preparations, which have been in the news, and many families are drawn to them. So cannabis preparations, they act on what is called the endocannabinoid system in the brain and beyond. And there are two receptors, the CB1 receptor, which is mainly in the brain, and CB2 receptor, which is mainly it involves the immune system. And the mechanism of action of is thought to be neuromodulation of the synaptic transmission. And their use in neurodevelopmental disorders is thought to be due to the thinking that there might be dysfunction of the endocannabinoid system in these disorders. And there are two preparations available. One is THC, or tetrahydrocannabinol, and the second is CBD, or cannabidiol. CBD is the one that is being studied for use in various conditions, because THC is the active psychoactive compound in cannabis. And these CBD has interactions with the serotonergic system and the GABA pathways, which is thought to affect the reduction in symptoms. For now, CBD is FDA approved for only 2 rare seizure disorders. There are some preliminary studies that are being conducted, but the data currently is not convincing to have the routine use in reducing co-occurring conditions in neurodevelopmental disorders. Some of the concerns relate to general concerns that we have with other herbal preparations, because there may be variability in doses and purity of the preparation, depending upon the pharmacy. These Preparations may also interact with other traditional psychotropic medications. So to conclude, problem behaviors can have a negative impact on a child with neurodevelopmental disorder. They can prevent learning, lead to caregiver burnout, and affect the family's quality of life. Understanding and treating problem behaviors requires a multidisciplinary approach. Any change or worsening of behaviors should spur an evaluation for a co-occurring condition which may be treatable. Safety concerns typically guide the level of care. Behavioral approaches are usually tried first, but if not successful, a combination with thoughtful medication management may be helpful. At this time, most evidence exists only for risperidone and aripiprazole for treatment of irritability and problem behaviors. Newer approaches are being investigated, such as with the cannabis preparations. At this time, the evidence base is limited and more studies are needed. I thank you for your attention and welcome any questions that you may have.
Welcome everyone to the Understanding Problem Behaviors in Neurodevelopmental Disorders Q&A. My name is LeeAnne Green Snyder. I'm a clinical research scientist for Searchlight, and I am joined with Dr. Rajneesh Mahajan. And we're excited to get started with the Q&A session and address some of your questions. So for this session, you'll be able to see and hear me, but I won't be able to see and hear you. So please ask your questions in the Q&A chat box. And please remember to avoid including very personal information or personal health information, PHI, for your own privacy. And we apologize in advance if we can't get to all of your questions. We're going to try to cover as many as possible. Since there are many genetic groups here today and many individuals, it might be difficult to answer some specific questions. So let's get started. So first question here, we have, what are some of the promising medications to treat anxiety and aggressive behaviors in autistic children?
So in clinical practice, generally for anxiety disorders, the medications that are used are the SSRI medications. These are medications like Prozac, sertraline, citalopram, Lexapro. These medications are used as first-line medications. For aggressive behaviors, it depends upon what the cause of the aggression is. And for example, what is the co-occurring condition in the child that might be driving the child to be aggressive? And typically it is not just medications, we also have non-pharmacological interventions. For example, communication difficulties can lead to aggression. So you want to have a good speech and language evaluation before you go to medications. Or you want to have a thorough evaluation for ADHD symptoms, because sometimes poor impulse control can lead to aggressive behaviors. So it really depends upon the cause, and it's a very complicated topic, and it can take time to do a thorough assessment before a medication is prescribed.
Very good points. And in fact, another question that's come in is related to this. You just mentioned impulse control, and a parent is asking, impulse control is a huge issue for our child. And when the impulse is so strong, how can you implement a behavior plan or replacement behaviors when it seems the impulse overrides all? So do you have any other suggestions or ways of looking at that?
So that's a great question. And I completely agree that poor impulse control leads to a lot of problems. And the issue can depend upon the age of the child and what the diagnosis is. most commonly in younger children, and when I say younger, I mean school-age children, poor impulse control most frequently is related to ADHD symptoms. Because in ADHD, there are three domains of symptoms. One is the inattention, second is hyperactivity, and third is impulsivity. Inattention and hyperactivity usually don't cause as much disruption as much as impulse control does. It tends to improve with age, but you can also have poor impulse control in teenagers if there are co-occurring mood disorders, for example, or challenges with regulation of behavior. So all these have underlying impulse control problems, and the treatment may depend upon what the cause is. Behavioral approaches can help to a certain extent, but in younger children, school-age children, if, for example, the impulse control problems are occurring in context of ADHD symptoms, then treatment of ADHD symptoms is recommended for better impulse control. In older children, if there's a mood disorder, for example, somebody has bipolar disorder, for example. In that situation, treatment of bipolar disorder is recommended. And there's a whole range of medications that can be used. Again, you also want to have non-pharmacological approaches to treatment. You want to remind constantly. ABA therapy can focus on better impulse control and reminders. Sometimes children, they will walk out of the house impulsively, or they run out to the street, which can be very dangerous. In that situation, changing locks on the doors or those kinds of interventions might be helpful. Close monitoring is generally recommended. So impulse control is huge, definitely, behavior-wise.
Has many facets and many consequences.
Correct.
Yes. So you mentioned ADHD medications and treating ADHD if the impulsivity is part of actually an ADHD picture. So how about in the context of intellectual disability or severe, significant developmental delays, and there are difficulties with attention or maybe restlessness in school? How does ADHD treatment or ADHD medication treatment work in that kind of situation?
So again, it depends upon the symptoms. So if, like I said, there are three components of ADHD. One is the inattention, second is hyperactivity, and third is impulsivity. So hyperactivity and impulsivity usually go hand in hand. And the stimulant medications that are used as first-line medications typically for ADHD symptoms, they address all three categories of symptoms. The challenge is that they wear off. That you can't give them later in the day because they can impact sleep. In those situations, you may have to combine them with medications other than stimulant medications that might be in the system 24 hours. And in patients with intellectual disabilities, again, the response of the medications may not be as robust as you would see in children who don't have any developmental disabilities. The effectiveness of medications in typically stimulant medications in a major study that was done, the MTA trial, they found that 69% of the participants, they responded to the use of stimulant medications. There was another study, for example, done in autism spectrum disorder a few years later, and they found the response rate was 49%. Similarly, in intellectual disabilities, the response may be less than what you would see in somebody who does not have developmental disabilities. But that does not mean that they cannot be tried. In my practice, I frequently use combined medications. If there's a lot of impulsivity, a lot of hyperactivity, I may start with an alpha agonist medication like guanfacine or guanfacine ER or clonidine rather than a stimulant medication. And once I have the impulsivity and hyperactivity under better control, then I might add a lower dose of stimulant medication. So in other words, it depends upon what symptoms need to be addressed. And the treatment is targeted to the symptoms.
Mm-hmm. On that note, someone's followed up on this discussion by asking for an example of what hyperactivity and impulsivity might look like together in day-to-day life, to give an example. And I might add, in particular, perhaps an individual with a neurodevelopmental disability.
Right. So for these symptoms in a child with developmental disabilities, you might see the same inability to sit still, moving constantly. You might have some stereotypic movements which might be exaggerated if they are, agitated or, and so they may constantly move. There may be increased rocking, even tic-like movements or other abnormal movements. They may elope. They may run out. They may run out of the classroom. They may run out of the house. These symptoms may be mixed in with sensory difficulties, sensory sensitivity. So the child may be climbing furniture, jumping up and down. And sometimes it can be dangerous when they climb to a height and they're trying to jump off from a height. Mm-hmm. So the other form of impulsivity that might be seen is, like I said before, aggression, impulsive aggression. So somebody who is, for example, nonverbal, and they are frustrated because of ADHD symptoms. They're unable to focus, they're unable to sit still, and demands are being placed on them. So in that situation, they may impulsively hit at the nearest person, or they may engage in other disruptive behaviors. So all this can be triggered by impulsivity.
Yes. Thank you. Thank you for those examples. It was very helpful. And in our last minute here, a parent asks, my child has very limited speech. So could a comprehensive psychiatric assessment still be done?
Absolutely. I mean, if you suspect that there are, or the child has behavioral issues, and remember that the threshold for having an evaluation is the parent's concern. So if you have any concern about the child's behaviors or their development, most child psychiatrists who work with children with developmental disabilities, they do a thorough developmental exam also as part of the evaluation. So they take into consideration speech and language difficulties, developmental milestones, mm-hmm. What is typical and what is atypical development, because all of those things can have an impact on the behavior mm-hmm. as the child grows older. So certainly, if you feel that your child needs an evaluation, you should go for it.
Thank you, Dr. Mahajan. Thank you so much. And thank you everyone for joining this Q&A session today. We hope you learned valuable information about problem behaviors and treatment. Please click on the next session to join the interactive speed sharing brainstorm. And thank you again, Doctor.
Thank you very much. Thank you for having me.